Just wanted to put it down. Yeah, thanks a million. Hello everyone and welcome to QITalktime. Thanks so much for joining us today. We're delighted to have everybody with us. My name is Roisin Breen. I work in the Quality Improvement Division, and today we're doing the second of our QITalktime Autumn Winter series, which is going to be on VTE, which is blood clots, tackling an increasing problem during COVID-19. We are delighted to have Professor Fionnuala Ní Aonla and Anne-Marie O'Neill with us today. Also, we're doing it a little bit different. We have Ciara Kirk with us online, and Ciara is the medication safety lead that works in the quality improvement team, and she's going to be acting as host because she works very closely with both Fionnuala and Anne-Marie, and would be better placed as she knows a lot indeed about this topic. So thank you, Ciara. I might hand over to you and you can introduce our speakers, and welcome to everybody online. Looking forward to an interactive webinar. Ciara, are you okay there?
Yes.
Yeah, perfect. That's it. Yeah, all
okay.
Good. Yeah.
Was that? Did you miss that?
No, you can start again. Oh. Actually, just with a little bit of interruption. Yeah.
Okay, thanks. Yeah, so welcome to QITalktime, and we are delighted to present. We had been scheduled to present back in March, and VTE has become even more of a problem with COVID, in addition to the issues that were there beforehand. So it's my pleasure to introduce Professor Fionnuala Ní Aonla and
yeah, I'm so sorry, everyone. We seem to be losing Ciara's connection. Ciara, I don't know whether it's a computer issue or a sound issue, but we're seeming to lose you through the platform. So I might just continue on. So Fionnuala is a member of the World Thrombosis International Steering Committee, and she's an Associate Director of the Wellcome Trust PHRB Irish Clinical Academic Programme. She's privileged to treat patients affected with thrombosis and has a strong interest in women's issues in thrombosis and hemostasis. And then we're delighted to have Anne-Marie, and she's a thrombosis patient and a founder member of Thrombosis Ireland, and her mission is to see both a mandatory VTE risk assessment in hospitals and statistics for VTE made available to all. So thanks a million, and apologies for Ciara's connection difficulties. So we're going to have to actually, Ciara, can you click on the screen there, or will I might share actually my screen. Sorry about this, guys. Naomi, would you be able to share the slides there for us? Apologies for this delay. Ciara has dropped her connection, and Anne-Marie and Fionnuala, are you still with us?
We are, yeah, thanks.
Yeah, so sorry about this connection difficulties with Ciara.
No problem, Roisin, take your time.
Yeah, so Naomi will share
I'm going to send it back to you, Roisin, if that's okay.
Okay, perfect.
Yeah, bear with me for 2 seconds. There we go. Now, Roisin,
okay,
you could do it now. No problem.
Yeah. Okay, just give me 1 second to get the slides up. There's always something with these platforms. Okay, I hope everyone can see the slides now?
Yeah.
Yep.
Yeah, perfect. Just give me 1 moment there. So, apologies for this. So just getting the slides. So Okay, so Naomi, would you like to just do some quick housekeeping before we hand over to Fionnuala? Thanks.
Yeah, sure. Just to let everyone know, as you said, you could use your computer or the dial-in, which when there's connection issues is handier, and the details are on the chat box as well. And please, you could write your comments, ideas, or questions on the chat box as well. Thank you so much and enjoy. Thank you.
Brilliant. Okay, and also we are active on Twitter, so if anyone would like to tweet, you can hashtag QITalktime and follow us at QITalktime as well. And there will be a recording of this available afterwards up on the website on our QITalktime webpage. So I'm going to put on and hand over now to Fionnuala. Thank you very much, Fionnuala, for joining us.
Thank you very much, Roisin, for the very kind introduction and for involving both myself and Anne-Marie today. It has been a very busy time for us, and thank you to all of you for your assistance and leadership. Venous thromboembolism is a topic very close to our hearts. It comprises usually deep vein thrombosis and pulmonary embolism. It affects millions of individuals worldwide every year, and over 350,000 people are reported to die every year as a result in 6 European countries. Not only that, but it's the top cause of tragic direct maternal deaths in the UK and Ireland reported in triennial reports. In other words, VTE is responsible for more deaths than HIV, breast cancer, prostate cancer, and motor vehicle accidents combined. Next slide, please. Next slide, please. But not only that, VTE not just causes tragedy, but causes long-term morbidity. And complications include chronic thromboembolic pulmonary hypertension, and that's just the tip of the iceberg that can happen after pulmonary embolism, because it can also be associated with post-traumatic stress and anxiety and exercise limitation and reduced quality of life, and also post-thrombotic syndrome, deep vein thrombosis. Confers a huge economic burden, but also markedly reduces DVT's patients' quality of life to a similar degree to chronic obstructive airways disease and also arthritis. And this is something that is sometimes forgotten. Next slide. Of particular relevance to our talk today is hospital-acquired thrombosis. And this is any VTE that occurs during a hospital admission, but not only that, it can be a VTE that occurs within 90 days of discharge. And data suggests that numerically more events can occur in some cohorts within 90 days of discharge than actually occur during the hospital admission. So it's really important that we're aware of the potentially preventable leading cause of hospital-acquired mortality. Next slide. It's very common. You'll be surprised to hear that at least half of all VTE events are related to hospital admissions. And it has been reported in other jurisdictions that hospital-acquired thrombosis represents a leading preventable cause of hospital death. And I suppose what we're all trying to do from a patient safety perspective is never miss an opportunity to save a life due to VTE. Next slide. So why not simply give every admitted hospitalised patient in Ireland thromboprophylaxis? It's because risk assessment is absolutely crucial. So the ACCP conducted a systematic review back in 2011 and did show, as you might expect, that giving pharmacological thromboprophylaxis reduced pulmonary embolism in hospitalised medical patients, but did so at the expense of an increased risk of bleeding, with no effect on overall mortality. And this is why, as Anne-Marie said, VTE risk assessment and appropriate thromboprophylaxis is so important and must be completed for every hospitalised patient. And huge congratulations to Ciara, who's on the line, and Dr. Philip Crowley and the entire team for the work done in the VTE Collaborative, a hugely impressive body of work, which showed that while there is a lot of good work being done on the ground, we do have a way to go in terms of this important patient safety issue. Thank you. But the good news is it can achieve very impressive results. So data from the UK, where VTE risk assessment is mandatory and appropriate thromboprophylaxis as part of this package of care, which does of course include increased VTE awareness as well. Leicester found and reported that this package can reduce VTE-related deaths, which is quite staggering. So in this huge countrywide study in the UK, they demonstrated a significant reduction in both VTE-related post-discharge deaths less than 90 days, and also primary VTE post-discharge deaths. In other words, VTE risk assessment, implementation of appropriate pharmacological thromboprophylaxis, and of course awareness can reduce deaths, can save lives. Trend by the NHS. Next slide. What about Irish data? Well, first, a year or two ago, my colleague Dr. Barry Cavan, UVT consultant in the Mater Hospital, in collaboration with the Ireland East Hospital Group Working Group on venous thromboembolism, led by Professor Marie, and were commissioned by Professor Marie, previous slide, thank you, and commissioned a very impressive body of work demonstrating an expected incidence of VTE 1.44 per 1,000 per annum in this large hospital group. And for the first time, we revealed data that nearly half of all VTE events were recorded as secondary. And this is probably an underestimation of hospital-acquired thrombosis, because in this body work, it was not possible to detect readmissions. So even within hospital, half of all VTE events were certainly hospital-acquired events. And the highest incidence was in people who are over 85 years of age, because the risk of VTE rises with age. Next slide. But thanks to a phenomenal efforts and commitment to patient safety and leadership at the very highest level, and a huge shout out to the QI directorate, to the acute hospitals division, there has been a key performance indicator launched, which was reported for the first time in November 2018. This reports the effect of achieving this reports a KPI estimating hospital-acquired VTE in Ireland, and it is via the Acute Operations Office. It was reported for the first time, as I said, in November 2018. The rates of VTE associated with hospitalisation for all hospitals are now included in the QDR circulated by the HSE BIU. In other words, we now have very high quality data and very granular detail on what precisely are the rates of hospital-acquired thrombosis in each Irish hospital, in each hospital group in Ireland. Data are crucial in driving quality improvement. And thank you to all involved, because this is indeed a very, very powerful and welcome step forward for patient safety in the area of VTE. Next slide. So this is an example of what the reports look like, and it really is very informative. So what we have here is the reported rates of hospital-acquired VTE per 1,000 admissions for each quarter. Overall, we have the national totals from Q1 of 2018 all the way through to Q4 of 2019. And don't forget, of course, that these reported rates from the BIU are by definition 5 months in arrears, because they do include, and this is great, readmissions. As I said, hospital-acquired thrombosis includes not just events that happen during a person's hospitalisation, but also events that happen after discharge. And these can present as apparently primary VTE events. So this is the foundation of an enormous body of work. So the national totals are shown here, and you can see, for example, what the individual group rates have been in each quarter, including, just go back to the previous slide, apologies. Thank you. So the red line here, for example, at the top represents rates from the Dublin Midlands Hospital Group, and for example, the line in green, the Ireland East Hospital Group. So it really is a very impressive level of data that we have available to us per quarter. Next slide. And just to show you what can be achieved, these are monthly inpatient rates. So of course, the total rates include readmissions, and they would be 5 months in arrears. But just to show you how these data can give us a very valuable insight into rates of VTE in hospitals. And these are the in-hospital VTE rates per 1,000 discharges per month from Q4 2017 right up to the present. And what you can see here is an interesting, potentially worrying trend to potentially an increase in national in-hospital VTE rates per 1,000 discharges. And intriguingly, going back as far as October 2019. And of course, numerically, discharges have decreased. So I suppose in the COVID era, the case mix has dramatically, changed, and that could explain, as you'll hear later, some potential mechanisms that could explain some of the differences that we're seeing from the early months of 2020. However, we truly don't yet have a convincing or a convincing hypothesis for what may be driving this trend to an increased rate back in October, November. It is interesting. But I suppose the key point here is that data can guide us. We need data in order to drive quality improvement. And otherwise, we would simply be in the dark at these really challenging times. So thank you to all involved. Next slide. Because these truly are challenging times from a thromboembolism perspective. From early on, it has been very clear that coagulopathy can affect up to 1 in 5 patients with severe COVID-19 and is associated with a need for critical care and is associated tragically with mortality. COVID-19 coagulopathy is characterized, as some of you already know by now, with an elevated D-dimer and mildly elevated laboratory coagulation times, including the proton and OCT. I might just suggest that if you're not speaking, you might mute your microphone in the background. There's a little bit of background noise there. Thank you so much. And in particular, elevated D-dimers appear to be associated with poor clinical outcomes. And why is this happening? There's a huge amount of work being done in this space. The concept in particular of immunothrombosis has been coined by many groups around the world. And it describes a well-characterized response to pathogen or damage-associated molecular patterns, and includes the expression of intravascular tissue factor and the development of neutrophil extracellular traps, lattices consisting of DNA and histones that activate coagulation through a variety of mechanisms. Immunothrombosis is postulated to play a key role in COVID-19 mediated coagulopathy through extensive interstitial immunocyte activation. Next slide. Endothelial activation also appears to be an important feature, with sometimes dramatic increases in plasma levels of von Willebrand factor and factor VIII. And accumulating data suggests that endothelial activation and indeed endothelitis may represent potential mechanisms for these observations. And what are we seeing on the ground? Summarized beautifully by a recent meta-analysis by Dr. Sihanai and colleagues in Austria, including 66 studies, just over 28,000 patients, including 1 in 5 of these being ICU patients with COVID-19. The overall VTE prevalence estimate was 14%, 40% with ultrasound screening and just under 10% without screening. And subgroup analysis revealed high heterogeneity, with a VTE prevalence of just under 8% in non-ICU and 23% in ICU patients. So we certainly are seeing a higher rate in critical care patients affected with COVID-19 than in ward patients affected with COVID-19. And the prevalence of pulmonary embolism in non-ICU and ICU patients was 3.5%. Next slide. Next slide, please. And based on this urgent challenge, a group convened very quickly under the leadership of Ciara Kirk-Philippoli and colleagues. And I would draw your attention to these guidelines, which are available on the HSE website. The easiest way to find them is to Google the HSE COVID repository and search VTE. And they include the interim guidance on VTE prevention in people with COVID-19 in the community or residential setting, and the COVID-19 interim guidance and VTE protocol and patient information for acute hospitals. Next slide. So let's talk through these in some detail, because they do represent a slight progression above and beyond what had been recommended already. So I would draw your attention to the fact that it is not new for a VTE risk assessment to be recommended in all Irish hospitalised patients. And that was already recommended in the fantastic HSE guideline. But you can see now that this guideline does draw our attention to COVID-19 as a VTE risk factor for hospitalised patients. So patients with COVID-19 are considered at risk of VTE, and if this risk factor is present, we simply proceed to the next step. And before we move to the next slide, I draw your attention to the leadership that has been shown by HSE colleagues in demonstrating the importance of VTE risk assessment. What you can see below is components of the Padua prediction score, which is recommended nationally for all patients who are hospitalised in Ireland. Next slide. So following the completion of the VTE risk assessment, we move on next to the bleeding risk assessment. So again, all patients hospitalised with COVID-19 will be considered at increased risk of VTE. We next have to determine whether there is anything standing in our way to prescribing pharmacological thromboprophylaxis. And this is called a bleeding risk assessment and includes the parameters that you can see here, including commonly low platelets, the presence of a bleeding disorder, very, very high blood pressure. Next slide. We then move on to recommendations on thromboprophylaxis. So let's just recap. Patients with COVID-19, no, previous slide, thank you. Patients with COVID-19 are automatically considered at elevated VTE risk. If they don't have contraindications from a bleeding perspective, we then move on to consideration of pharmacological prophylaxis. And in this very clear guideline, compiled very rapidly by the HSE to respond to the COVID-19 challenge, patients affected with COVID-19 are recommended to receive pharmacological thromboprophylaxis with the agents with which you are all very familiar. And I won't go through this in detail, but it does provide a very clear, very clear recommendations on dosing bands according to weight and according to renal function. So huge congratulations to all involved. Next slide. And finally, this is incredibly important. And I will be handing over to Anne-Marie very shortly to talk more about this. Possibly our top take-home message, that all patients with COVID-19 and all those without COVID-19 should be informed about the signs and symptoms of venous thromboembolism before they go home. Because let's go back to the beginning. We never want to miss an opportunity to save a life. If a patient or their family members are aware of what the signs and symptoms of a VTE are, they will be in a position to return to hospital and be diagnosed and appropriately treated. This can save a life, and this can prevent lifelong complications. Next slide. Next slide, thank you. Before I hand over to Anne-Marie to talk about the fantastic Thrombosis Ireland HSE alert card, so I want to give a quick word on community and residential care settings. Another incredibly important and urgent guideline that was responded, that was a response from a great need and a great clinical imperative. And to summarise, in people in the community or in residential care settings, VTE prophylaxis is not routinely recommended for people who do not have COVID-19. And we know that the risk of VTE is not known to be raised in people with mild COVID-19. Therefore, it is not recommended for people who have asymptomatic or mild COVID-19. People with moderate or severe COVID-19 in the community or in residential settings who are transferred to hospital should be risk assessed and receive prophylaxis in hospital. And this is really important. Pending the emergence of further evidence and on an interim basis, prophylaxis may be considered in people with significant functional decline from baseline due to COVID-19 who are remaining in a residential setting. In other words, would be perhaps in other scenarios qualifying for a hospital admission, but where this admission isn't happening. And this is, I suppose, we are almost in a data-free zone here, but it is a challenge, and huge thanks to the multidisciplinary team who were involved in the compilation of this very sensible guideline. Thank you. Next slide. Next slide. Thank you. And at this point, it's an honour to hand over to the very inspirational Anne-Marie O'Neill. appease the
Before we do that, guys, just before we do that, Anne-Marie and Fionnuala, thank you very much for that. I might just interject with one or two questions that have come in while you were speaking there, Fionnuala. Thanks a million for a very informative talk. And Dr. Philip Crowley, who's the National Director for the Quality Improvement Team, has just been in touch with me to say again thanks and congratulations, and that we as a team are delighted to be part of this very worthwhile work on an ongoing basis. So we have had some questions into the chat box, albeit it is a little bit quiet, so don't be afraid to ask any questions for our speakers here. But just one question has come in from Kathy Henbury, and she's asking about how can you be definite that it is hospital associated?
Absolutely, that's a great question, and in fact it's a straightforward question. So it is defined as a VTE occurring in the context of a hospitalisation is defined by, I suppose, type coding. So a primary VTE, or one which causes a patient to actually present to the hospital, is coded as DX1, and a secondary VTE event, which is defined as potentially hospital associated, is defined as the hype, the hype DX2 to 99, or a readmission. But Kathy's absolutely right that we can't be 100% certain that these are truly hospital-acquired events unless a full, detailed, granular look back is done at the discretion of the hospital thrombosis team on each one of these cases. And I know that this body of work has begun in isolated hospitals, but it is certainly, Kathy, something that will almost certainly become more, I hope, more widespread as awareness rises. Thank you. That's a really important question.
And another question as well, Fionnuala, just regarding the KPI, and I suppose from a quality improvement perspective, it is great seeing your data for improvement there over time and trying to annotate, I suppose, exactly where you're seeing the peaks and the troughs, and trying to explain variations within the data. But just a little bit more about the KPI. Who gets the data about the KPI in the hospitals, and where does it come in?
Yeah, again, it's a great question. So it is reported, as you know, it's circulated by the HSE BIU, and Ciara, step in if you want to add to this, but it does go directly to each one of the hospital's CEOs, of the hospital group CEOs, clinical directors, each one of the hospital CEOs, clinical directors, and is then cascaded down the function. Do you want to add to that, Ciara?
Yes, so is part of the performance report. So the performance report reports on all of the KPIs that are in the service plan. So they're the core KPIs. So it comes in each performance report or performance profile. And there's also a trend report provided separately, specifically about VTE. So that has been going to hospitals. I can't remember the date the first one went, but it's been going for about a year and a half, I think.
It was November 2018, Ciara, I have here. But
yeah, so nearly 2 years. Time is flying. But I think, I know, I think, was it Maureen Flynn made a comment there, great to see data driving improvement. I think it is certainly driving attention. So yes. I think it is reaching people at management level in the hospitals, generating some interest and or concern. And obviously what is important is that then results in quality improvement to really try to drive up the appropriateness of prevention that people are getting and the information that they're getting, and that then hopefully we could see a decrease, particularly in the inpatient VTE rate. But unfortunately at the moment what we're seeing is that there's actually been an increase, and that we expected to see an increase with COVID, but that increase actually is there from October of last year. So we're not quite sure why that would be the case, but it's the case nationally, and it's a significant shift to a higher rate of VTE. So I think it's even more compelling that we would attempt to really work at achieving improvement and better prevention.
Thank you.
Yeah.
Thanks.
And I suppose as well, given the associated risk with COVID as well, we are going to see, I would imagine, in our data over the previous months and coming months, an associated increase because of that as well. Would that be true to say?
Is that question for me, Roisin? This is Fionnuala.
Yeah, it's just a comment rather than a question, really.
Yeah. I think we will have to wait and interrogate the data, and I suppose we have nice data on what overall rates of COVID associated VTE have been internationally, but what we can't predict is how rates of primary VTE might behave. And there was a worrying paper again from the group of Chihanai in Austria, suggesting that I suppose we've similar worrying signals that we've seen with other conditions like stroke and MI, that actually people might not be presenting as frequently with non-COVID associated Ps, if that makes sense. So I don't think we can, we'll have to watch the data. It's very difficult to predict. And those two may balance each other out. But the key thing is that we have these data, and I really can't highlight it strongly enough how important it is that we have these data to really interrogate our practices and focus improvement strategies. Thank you.
Fantastic. Just two more comments and then we'll hand over to you, Anne-Marie. Thanks very much. So Muriel Pate has directed people through the chat box about the VTE Risk Assessment cards that were supplied to hospitals in January, February 2020. But if you're unsure, you can contact safermeds@hsc.ie for your local contact if you're running out of those for your hospitals. So that's a good contact to have. Thanks for that, Muriel. And another question from Kathy as well. So has any consideration, just if you can mute if you're not speaking, sorry. So has any consideration been given to how to capture data on patients not captured from HIPE? So i.e. those patients who are managed in the community? Very good question.
It's a great question. It's certainly been identified as a gap. Now it's I think as well what you're getting, what you're alluding to there, Cassie, is potentially also the fantastic advances in ambulatory DVT pathways where patients are diagnosed and treated and sent home very quickly. And this is this is advocated by several international guidelines, but it just is an area where additional strategies need to be sought to gather these data because they're not gathered currently by HIPE. But yes, it has been identified as an important issue. Thank you so much, Kathy.
Yeah, okay. I think that's everything from the chat box for now. So we might hand over to Anne-Marie then, if that's okay.
Perfect.
Thanks, Fionnuala. Have we got Anne-Marie there?
Hi everybody, sorry I was still muted. Thank you to everybody who's joined us today, and I really appreciate being part of the conversation. It's always good to get the patient perspective, and I really appreciate being able to do it. I suppose I'll start with the fact that the alert card was, as Muriel mentioned in her chat, it was 1 million of them were printed by the HSE and delivered to your hospital around the country. So they are available, and if you shouldn't have run out by now, but if you have, it would be great news because it means you're distributing them to your patients, and you can contact safermeds.ie to order more. It started really as a way of making it simple for you to impart that really important thrombosis 3 message, the risk factors, the signs to look for, and how important it is to act fast. So it's a little explanatory card. It's laminated, it folds over and fits in somebody's wallet. And the idea is that every patient, admitted or not into your hospital, everybody that passes that threshold should really receive the information about blood clots so that they have the opportunity to protect themselves, particularly when they go home. Every patient trusts that you have their back, and they know that when they're in hospital that they're protected. But when they go home, there's a certain amount of responsibility on them, but they can't take that responsibility if they haven't received the information. So keep that in mind whenever you're sending your patients home. They need to be aware of the risk, they need to be aware of the signs, and they need to know that they have to act fast if they suspect a blood clot. They won't do anything if they don't know anything about it. And we know that because we have story after story of young, old, male, female patients that have contacted us that have been affected. Tragically, some have lost their lives and others have survived to tell the tale, and they want to tell their tale, and the stories are coming in droves. So what I'll say is, as Fionnuala had said, we've an opportunity here to save a life, and that little piece of information, it doesn't cost a whole lot. It's a couple of minutes out of your time. I'll give you a little bit of good news, a good news story. I don't know if you've seen, we've a multimedia campaign with a TV animated ad on TV3 at the moment. And there's a young skateboarder on it, and it came from an actual patient story. So Millie, during COVID, 18 years of age, living in Limerick, bought herself a skateboard to occupy herself. And day one, of trying out her new skateboard, she broke her ankle, fell and broke the ankle. So she ended up in hospital. She needed surgery for pins and plates. But before she left the hospital, one of the nurses, and I haven't traced her yet, and if you're listening here, please contact us because we'd love to talk to you. One of the nurses in Limerick University Hospital sat her down, gave her an alert card, and basically told her that if she gets any of these particular signs, to mention it at her next visit or come straight back. And a week later, she was back to get some x-rays, and her cast changed. And she mentioned that her ankle was much more swollen and really hurting her. And they scanned, and she had a DVT. So that couple of minutes that nurse took really made a difference. These cards are working and they will save lives. So please use them. Next slide. Also, cards are available on thrombosisireland.ie website, and we've actually, it was my COVID project, I decided to convert, get them translated into 17 different languages, because there were some requests, particularly in the maternity hospitals, that English isn't everybody's first language, and it would be a good resource. So they're available in 17 different, it's available in 17 different languages on our website for download. You can just print off an A4 page and hand it to a patient. Maybe when we eventually get some more funding, we'll print some in a few different languages and make them available for order. But at the moment, we just have them available in English. Next slide. So the bottom line is that your patients trust that you are providing the best available VTE risk assessment, the best available prevention, diagnosis, treatment, and recovery pathway for them. They trust you that that's happening. Next slide. We have done a lot, but there's a lot more to do. And it's disappointing to see the rise in VTE incidents in hospital, because we've been working really hard for the last 5 years really on this to try and raise awareness and to make a difference in the hospital. But the bottom line is we need that VTE clinical program. We need that funded VTE clinical program where we look at the big picture and we start from scratch with a clinical VTE lead overseeing it. At the moment, we're tackling it from lots of different directions, from the patient perspective, from the hematologist perspective, from quality perspective, from the acute hospital perspective. We're looking at it from lots of different things, lots of different directions. But from the patient's point of view, we need that clinical program. We need to know that doesn't matter what hospital we attend, that we will get the same standard of care. And that is not happening. Some hospitals are doing absolutely exceptionally well, and it's usually because we have some VTE warriors out there who are really implementing it in the individual hospitals. We've 32 hospitals, not 320 hospitals. We should be able to have that same streamlined treatment, service, protection and safety for our patients in every single hospital. I know we have to start somewhere, and I think probably the best place to start is with each individual hospital setting up their own VTE working group. At least then they can look at their hospital and see what they can do, and then maybe liaise with Thrombosis Ireland and with Ciara and Muriel in the quality improvement section, and we can help in any way we can to get the ball rolling within your hospital while we're waiting on this funded VTE clinical program. But let's not wait for it, let's start now. So if you could look at your own hospital and see, do you have one, and how to go about setting up one, that'd be great. I think we need an assigned VTE nurse in each hospital to oversee the VTE care and to basically run that VTE working group. And I think that should happen in all 32, not just in the bigger hospitals, but there should be an assigned VTE nurse in every hospital. And as Fionnuala talked about earlier, VTE risk assessment, in our opinion, from the patient body perspective, needs to be mandatory. There's absolutely no excuse for not assessing a patient. How can we know, how can you know if a patient needs prophylaxis or extra care or extra conversation around safety when they go home if they haven't been risk assessed? It's crucial that everybody is risk assessed, so you know what you're dealing with, and you know if they need it or if they don't, or if they're a bleeding risk or they're not. It's crucial that we have mandatory VTE risk assessment. It has been done in the UK, and we've seen the figures there. It has brought down nearly by 10% immediately the incidence. And we're not talking just percentages here. We're talking, those percentages are people's lives or people's disability that they have to live with for the rest of their lives as a result of one of these VTE incidents. So we need to move on this, and we need to move on it fast. Education again would be a key pillar point within the VTE clinical program. And I'm saying don't wait necessarily for the clinical program. It's something we can work on today and tomorrow while we're waiting on the VTE clinical program. Education is crucial. People won't know. Healthcare professionals have got to be educated from talks like this, and also patients have got to be educated so they can protect themselves. Accurate VTE data is really my bone of contention, and oh my God, fantastic work is being done at the moment, and you can actually see we've now got evidence, and if we have evidence and we have an argument that people can't, push us away, we can say, look, this is what's happening and we need to do something about it. But accurate VTE data, to me, we have got to be capturing those people that just come in for an X-ray, that come through A&E and are sent home, treated at home. So at the moment, that I believe is being captured in some hospitals. I believe Limerick University Hospital are capturing that data. I don't know what other hospitals are capturing it. And I'd be interested to talk to somebody to see why we aren't actually capturing it in every single hospital. I think it's definitely something that we need to do, and it would make that VTE data a lot more accurate, because VTE is very treatable at home. And with the newer DOACs, it's happening more and more that people come, they present at the hospital and they're x-rayed and put on their medication and then sent home. But if we're not capturing that data, we haven't got a true picture. So we're back around to our clinical lead. We need that one person who is the boss. As I always say, we need the boss to give the instructions. We need the boss to look at the full picture and see what we do first, what we do second, what we do third, and a go-to person that every hospital can approach for recommendations. So that's how I think we can achieve this together. Again, centre point, We need that VTE clinical program, whatever we have to do to get it. Now more than ever, COVID has highlighted the dangers of blood clots even more so. That added risk, it affects so many different areas. It affects our cancer patients, our pregnant girls, our new moms, any hospitalised patient, and now it affects our young people from sports injuries, leg cast, long haul travel. It just can affect every single family, and we all need to get together, continue to pull together and make a difference here. We are making improvements. They're not fast enough for me, but of course they're never going to be fast enough for me. It's never going to be enough until we have it done, until we have that clinical program and we're, you know, actively educating, actively funding, actively seeing that line, that data line coming down significantly, because that data line is lives and we need to save those lives. Next slide. So mostly at these talks I told you about Millie's good news story, but here's two boys that didn't make it. Here's two boys that had potentially preventable deaths. I've spoken about Niall before at the VTE Risk Conference. He was 23 years of age. He hurt his knee. He had an exploratory camera to his knee and was sent home with an elastic bandage and a crutch. With no information about VTE, and his leg did swell. He thought it was from the procedure, and his mother thought it was from the procedure. They'd had a pre-op assessment and there was a lot of stuff about heart and lungs and everything, but absolutely no VTE conversation. And Niall, unfortunately, had an appointment 10 days later to go back and have his knee checked, but didn't go back. 6 days later, he went back to college and said he'd be back up to his appointment 3 days later. But unfortunately, day one back in college, he collapsed and was taken to Waterford General, and unfortunately died before his mum even got to him. And that was Niall. And then we've got John. John hurt his leg playing rugby, and was put in a leg cast. And the leg swelled so badly that he went back to the hospital and he was put in a bigger leg cast. And then he had 21 days of going back and forward to his local hospital, complaining of pains, breathlessness. And unfortunately, it wasn't picked up. And John passed away, leaving his young son behind and his partner and his family, who are still grieving and confused and angry that he presented with all these signs and nobody spotted it. But the family as well, when he got his leg cast, he wasn't informed of anything either, so he didn't push it. He trusted that people knew what it was. And not to end on a depressing note, but it's realism. If we don't inform patients of their risk, if we don't inform patients of the signs to look for, and if we don't inform patients how important it is to act fast, trust their bodies and instinct if they suspect a clot, to come screaming back in to get it checked. The unfortunate thing is we're going to have more young boys, young girls, or elderly, no matter what age, we're going to have more sad stories, so more deaths. And I just don't want that. I want us to try and stop this together. Thank you.
Thank you so much, Anne-Marie, for such a passionate talk there. Really appreciated, and such tragic stories that really are the impetus, I suppose, behind all of this work. And it's so obvious that there is so much improvement already that has happened, but as you were saying, a lot more to do. And as part of the quality improvement team, it's great to be involved in ongoing improvement. Ciara, I think, is still online with us, and yeah. we had 45 people online, which is fantastic. So now is your last minute chance to type in the chat box if you have any further questions for any of the panelists. We still have Fanula, we have Anne-Marie, and Ciara is online as well from the Medication Safety Programme.
Yeah, thank you. If we just move on to the next slide, I just have 2 slides in terms of quality improvement. So I'm hoping that anyone on this call is eager maybe Anne-Marie, I don't know if you can mute maybe.
Okay.
Thanks. The improvement collaborative, so some of you will have participated in collaboratives. So from 2016 to 17, we ran a quality improvement collaborative and 27 hospitals participated in multidisciplinary teams from each of those hospitals. So importantly, this was really, I suppose, the equivalent of on Anne-Marie's slide there, the VTE working group. So these groups were trying to improve the appropriateness of prevention so that each person was on the right prevention for them, for their risk, within 24 hours of admission. And really, I suppose, to make a long story short, this road is well traveled. So if you are embarking on either a first phase or subsequent phases of an improvement journey in your hospital, please go to the tools and look at what was learned from improvement or lack of it in those 27 hospitals. So overall, the appropriateness of prevention was improved by 1/3, which was a fantastic result. But not every hospital achieved that. And so we were able to work out what combination of things helped achieve improvement and what things were less successful, even some things that seemed like they should work and they didn't. So I think it is really well worth going back to that report. So it's on safermeds.ie. And it's in the, there's 2 sections, one for patients and public and one for healthcare professionals. So it's in the healthcare professionals side. We mentioned the alert cards. So Anne-Marie, produced these brilliant alert cards, and we managed to fund a large printing and distribution of them. So all hospitals should have a supply. If you want to find out who in your hospital got that supply, or you're trying to find it, or if you have any other queries about alert cards, just send them to safermeds@hse.ie and we'd be happy to respond to that. So the report contains a toolkit for how to improve and recommendations. And just on the next slide, the key learnings. So unfortunately, it's not as straightforward as doing one thing. But what we found, to summarize a lot of information in there, having a defined VTE protocol, so similar to what Fionnuala showed earlier, a protocol that tells people what the hospital policy is for risk assessment and bleeding risk assessment, and for the actual dosing of the medication and mechanical prophylaxis if necessary. So having a protocol, having prompts or alerts, such as a pre-printed section in a drug chart, or if there's an electronic system, a prompt there. Independent checks built into the system, so where there are either clinical pharmacists who have this as a very defined responsibility, or if there's an independent check that always happens, say at the post-take ward round, or nursing checks. So particularly in orthopedics, there's a series of checks, and also in midwifery, that there are a series of independent checks, and that means even if it's been missed at an earlier stage, it's picked up and acted on. And the education and information for staff and patients, I think Anne-Marie has illustrated just how important that is, for that patients get that information, but also that staff do. So not only that staff have information about how to prevent VTE, but that actually if somebody does present with signs of VTE, that all staff recognise that. So not just nurses and doctors, but physios, if people are coming in with an injury, that the physios will recognise it, and that all staff who might come into contact with people who are developing a blood clot, that they will be able to act on it. So in terms of the key components of what you need to do, having an improvement team, so that there are actually people working on improving this. And I know in some hospitals this might be something that there's a kind of improvement burst or effort or project for a certain amount of time, and then maybe you won't be focusing on it quite as closely, or you'll be moving on to a different aspect of it. We do have guidance in there for measuring appropriate prophylaxis, which is it's a proxy measure. It's not an outcome measure, but it's telling you how good your prevention is, and that there is some sort of governance oversight for it. So whether it's a specific thrombosis committee or that it's an agenda item on another committee. So in some cases that would be on a drugs and therapeutics committee or a quality and safety committee. So I won't go on any further because I do think there are some questions that we would like to deal with as well. Will I pass back? Will we do questions and feedback now?
Yeah, thanks very much for that, Ciara. We actually, no further, everybody's been so clear in all of their content, no further questions have actually come into the chat box for us. So all the way through there, we have been putting in the websites for everybody as we went along, and there has been some difficulties around connection for some people, and I think even some of our presenters have had connection difficulties today, so very little we can do about that. Sometimes the network just doesn't support, so apologies, but this is recorded and will be put up online afterwards for everybody to access. There is the question here from Oshin, who joined late, but he was wondering about extra VTE prophylaxis for critical care patients, and that he's trying to find evidence of 0.5 milligrams kg BD dose.
Hi, Ciara, I can take that if you like. Thanks a million, Oisín. It's Fionnuala Ní. So again, one of the huge challenges that has faced us all is the lack of clear data on precisely what the rates of VTE are in association with COVID-19 associated critical care admission compared to other viral pneumonias admitted to critical care. What we do know, I suppose, is that the optimal thromboprophylaxis strategies in patients admitted to critical care and with viral pneumonias is poorly characterised in general. We simply have a lack of optimal data. So to respond to these unique challenges, and I suppose which have been assisted by the publication of increasingly large cohort studies, I know in the guideline prepared by the HSE, it is recognised that the optimal rating is not well characterised, but that individual multidisciplinary teams may perform a risk assessment and determine what for their unit represents the optimal strategy. Various international guidelines have different recommendations, Oisín, as you know, and even within guidelines, there's huge discrepancy between panel members on what the right thing to do is. And I think always when there are wildly different guideline recommendations, it highlights the need for excellent randomized trials. And thankfully, there are a lot of trials internationally addressing this precise question, which is very, very good news. It's really staggering to see how quickly these high quality international multi-center randomized trials have gotten off the ground. So it is possible that we will receive the data from the first of these trials within, we're told within months, which would be phenomenal, and particularly if, as is being suggested, teams work together. So maybe watch this space. Thanks, Oisín.
Thank you, Fionnuala, for that. We don't seem to have any other questions. Is there any final comments from Ciara, Anne-Marie, or Fionnuala before we sign off? Thank you so much for an excellent webinar.
Thank you so much, Roisin. Ciara, I agree with you. I think the education for the staff, including like physios, see patients every single day. So they're crucial, in my opinion, to be educated on this area. But I think everybody from the catering staff should be aware, because my idea is really that it should be a household name. Thrombosis, VTE, blood clots should be household words that people are familiar with, and that's the only way we're going to do this right. The information piece, it's got to be in everybody's home, I think. And then we can take it into the hospital from the patient perspective. And then if we have it in everybody's home, that means we're hitting the healthcare professionals at home as well and making them aware. I think the more questions we raise, the more people that want to know about it and attend the likes of these talks, the better. So spread the word and let's do more of them.
Yeah, and I think just you certainly have the blood clot information up, but it is important to note that there are particular groups and they're all kind of seen in hospitals. So it's anyone who's admitted to hospital and for 90 days after they go home, anyone who has active cancer or is receiving cancer treatment, anyone who's pregnant or had a baby less than 6 weeks ago, and immobility. So if someone has a lower leg, immobile lower leg cast, as in some of the cases that we had and Marie spoke about. So really there are particular groups, and we really want the cards or the information within the cards to get to people, everybody before they're discharged, everybody who has cancer, everyone who's pregnant, everybody who has a lower leg cast. So not all of those groups will be getting any prevention, but they do need the information.
Thank you so much.
Thank you.
Thanks, guys. And Grania Leach is echoing that about information is vital for the public. So maybe we will have another QI talk time in the new year to highlight further any further developments. But just so we're finished just after 2. So thank you so much again to Fanula and Anne-Marie for giving us their time today and for the excellent content. We really appreciate it. And also to Ciara and Kirk, who helped out from the quality improvement team. And just to say that our 2 weekly webinars continue, and our next one is on Tuesday the 20th of October, and it will be presented by Dr. David Weekliam, who is the global health lead within the quality improvement team. And it should be interesting talking about QI during COVID-19 pandemic. I suppose there'll be some stories from other countries which could be very interesting. So thank you very much again, and thanks for everyone online. We still have 38 people who remained on at the very end, so that's good. So thank you, and hopefully we'll see you at the next one. Thanks very much. Bye.
Thank you very much, everybody.